epidemiologist Kershaw, who is joining us today. Just to give you a little bit of background about Dr. Kershaw, she is an associate professor of preventive medicine at Northwestern Feinberg School of Medicine. She's a social epidemiologist whose research focuses on understanding the contributions of various aspects of the social environment on health, including social relationships, psychosocial stressors, and neighborhood conditions and resources. She has examined the social environment in the context of cardiovascular disease risk factors and outcomes, adverse pregnancy outcomes, and biological markers of aging. Dr. Kershaw is also interested in understanding how features of the social environment act and interact to influence eating decisions. She's been using discrete choice experiments, ecological momentary assessments, and agent-based simulation modeling to answer this research question. And so again, we're really excited to have you here, Dr. Kershaw. I'm gonna let you take it over and then we'll do your presentation and then follow up with a Q&A with the audience. So thank you again for being here with us today.
Thanks so much for having me. I will work on sharing my screen. Getting started. Okay, so the title of my talk today is Understanding and Addressing Structural Determinants of Cardiovascular Health Inequities. And so I divided this talk into two parts. So the first will be this kind of understanding part, and in that part, I'll go through some of the research I've done in the area of racial residential segregation as an example of as a form of structural racism. I'll go through the relationship, or the argument for segregation as a fundamental cause of health disparities, and then get into some work that we've done looking at segregation and CVD risk. And then I'll switch gears for the second half of the talk to talk more about addressing structural determinants. And this is more of an exploration of the ways that all of us as researchers can adopt a racial and ethnic equity perspective in the research that we do. So starting on the understanding part. So as I think we all know, Black-white health disparities are large and persistent in the US. This is a figure showing age-adjusted mortality and life expectancy between Black and white Americans. And we can see life expectancy on the right-hand side is much lower for Black adults than it is for white adults, and it has been since the 1900s, really. And one striking thing about this that the authors pointed out on the upper right is that the highest ever Black life expectancy, which was in 2014, is still below white levels seen since 1989. So these are large and persistent disparities that we're seeing here. And they exist for many major causes of death, one of which, and a large percentage of which, is due to heart disease. And there's a lot of research showing that the residential environment contributes to these racial disparities in cardiovascular disease risk factors and outcomes. This is a highlighted a compilation of findings from the EDIC cohort by Leviste and colleagues when he was at Johns Hopkins University. And what they did in that study, they really wanted to understand the role of place in racial disparities in cardiovascular disease risk. So they looked at all the census tracts in the United States in 2010 and identified those where Black and white individuals were living in similar environments. So at least 35% of Black and white adults had to live in those census tracts. And then they also wanted to make sure they had similar socioeconomic conditions, so that we're not talking about factors like gentrification that may drive this kind of shared living environment. So they identified places where Black and white individuals were living together and had similar levels of income and education. And they settled on 2 tracts in Southwest Baltimore for their study. And what they did is they compared a variety of outcomes, including hypertension, diagnosed diabetes, and obesity, which are highlighted here, and compared them for Black and white adults living in the integrated community in Southwest Baltimore and in national data. And so here you can see on the y-axis here is the Black-white ratio, or 1 would indicate there's no real difference between Black and white individuals in these outcomes. And what they found is that there were really no disparities in this community in Southwest Baltimore, even though we see these larger disparities in national data. And this suggests that Black and white individuals living in similar environments have more similar health outcomes. But the reality is Black and white people are not living in the same neighborhoods. So this is highlighted in this Brookings Institute document, but has been shown countless times. The neighborhood of the average white resident, Black resident, and Hispanic resident is markedly different. And understanding the reasons why individuals live in different neighborhoods may provide further insights into the best policies to effectively address health disparities. And so there are a lot of reasons, several reasons why Black and white people are living in different neighborhoods, but one driving factor is racial residential segregation. Racial residential segregation is the systematic sorting of individuals into different neighborhoods by race. So systematic is key here. It's not a random phenomenon. It's typically measured at the metropolitan area level or the neighborhood level. The metropolitan areas are often used because they represent labor and housing markets that shape residential segregation patterns. And the idea here would be that living in a segregated neighborhood could be harmful for your social and economic well-being, and as we argue further in this talk, health, regardless of where you live within that metro area. And then at the neighborhood level, the benefit of looking at segregation at this level is that it allows for an examination of heterogeneity within cities. And the idea here would be that Black people who live in a segregated neighborhood may have fewer opportunities and resources that again influence their social and economic well-being, and then in turn influence your health outcomes. So residential segregation, or living with a group with the same background, is a common phenomenon for most immigrant groups as they come to the United States. And for African Americans, this happened internally with the Great Migration out of the rural South in the early 1900s into the Midwest and East Coast. And at that time, living in shared communities could have been as much due to a desire to maintain social ties and informal social networks as due to discriminatory practices. However, unlike most other ethnic groups in the US, discriminatory practices at the government and in the private sector, particularly around housing and lending practices, coupled with intentional underinvestment in predominantly Black neighborhoods, led to persistent segregation throughout much of the 20th century, and it still remains high. On the right is just an illustration of this and really the systematic and kind of intentional nature of segregation, showing the racial and ethnic composition of Chicago community areas from 1910 to 2010. And this stark change from neighborhoods being over 90% Black, white to over 90% Black is really highlighting that systematic and the kind of intentional processes that were shaping these patterns. And this is something that really holds across household income levels. So these discriminatory practices really transcend income. So this practice by race transcends income. And this influences where Black people can afford to live or are allowed to live or given opportunities to live in a way that is damaging for their kind of the types of resources that they're afforded. So one consequence of this, shown by Reardon and colleagues, is that middle-income Blacks tend to live in poorer neighborhoods than middle-income white or Asian individuals. So a typical Black family, as they show and kind of highlight in this infographic, making $50,000 lives in a poorer neighborhood than the typical white family making $20,000. And we know neighborhoods are important for a lot of things, right? So they're important for the schools that your children go to or you go to when you were growing up, and that has an influence on your future earning potential. They're also a source of healthy social and built environmental factors that influence your health outcomes, such as access to healthy foods or safe places to be physically active. And it's for these types of reasons, the kind of opportunities and resources that are afforded to people in segregated or non-segregated neighborhoods, that led Williams and Collins to call segregation a fundamental cause of racial disparities in health. And so now I'm going to kind of outline this fundamental cause theory and the argument that for why segregation is a fundamental cause. So this is rooted in a theory laid out by Lincoln Fellon in 1995, where they argued that socioeconomic status was a fundamental cause of health disparities. A fundamental cause is one that influences multiple disease outcomes and affects these disease outcomes through multiple risk factors. It involves access to these kind of flexible resources that can be used to avoid risks or to minimize the consequences of disease once it occurs. And because of these flexible resources, this association between a fundamental cause and health is reproduced over time by the replacement of intervening mechanisms. So I think the argument that segregation influences multiple disease outcomes is present or evident by the large number of review articles that highlight the relationship between segregation and different outcomes, including CVD risk, adverse birth outcomes, cancer disparities, risky sexual behavior, STI diagnosis, and childhood asthma. And we've seen also in the past year how segregation has shaped who is falling susceptible to COVID-19 in terms of cases and outcomes. And this is an article by the Brookings Institute, report by the Brookings Institute highlighting these huge disparities or inequities in COVID cases and COVID deaths, this higher burden faced by Black residents, particularly in these historically segregated areas like Milwaukee, Chicago, and Detroit. So even these new diseases as they emerge, we see these disparities emerge pretty quickly after. And segregation affects these outcomes through multiple risk factors. So I talked earlier about education and kind of more socioeconomic and opportunities for physical activity, but exposure to violence and over policing can lead to increased disease risk through multiple pathways, including stress pathways, exposure to air pollution. So there are a number of pathways through which segregation and where people live and the resources afforded in those areas can influence disease outcomes. And so getting back to this flexible resources idea, individuals and groups deploy resources to avoid risks and adopt protective strategies. And these are resources like knowledge, money, power, prestige, and beneficial social connections. And these resources are important because they shape individual health behaviors and allow people to kind of adapt even when the profile or risk and protective factors change radically. So this is why we see this kind of pervasive link between segregation and health, because these resources kind of come with the opportunities that are afforded to people in different neighborhoods. And there hasn't been a lot of research showing this last part, this how the profile of risk and protective factors may change and influence health. But from socioeconomic status, studies on socioeconomic status, we can see this pattern occurring. And one example of this is with statin use. So prior to the introduction of statins, and shown in this kind of the black bars in each of these figures, higher income individuals were more likely to have higher total cholesterol levels. But with the introduction of statins, higher income individuals were the early adopters. They were the first to kind of know that statins were available and so beneficial, but then also were able to afford those. And so then you see in the bottom curves, the light gray curves, this flip of that gradient. And so that's the idea behind it, being able to adopt new knowledge and new interventions will lead to this kind of perpetuating these disparities over time. So now I'm going to show a couple examples of some of the work we've done looking at residential segregation and CVD risk. And I'm going to start just by laying out this great figure that my colleague Cheryl Barber designed, and it's part of a paper that we have under review on measuring residential segregation. And so the idea is there are many pathways, of course, linking segregation to CVD risk, and this happens over the life course. So historical and contemporary racist practices and policies that I alluded to in earlier influence segregation, drive segregation and associated differential access and exposure to health promoting and health harming features of the built-in social environment, which are shown in those purple boxes. These environmental conditions reinforce segregation and lead to further disinvestment. And then these unhealthy environments may lead to earlier onset of CVD risk factors through the breakdown of stress response systems and the adoption of poor health behaviors. In addition, living in neighborhoods with limited Access to clinics and pharmacies, for example, may result in lower rates of control for traditional CVD risk factors like hypertension and type 2 diabetes, and ultimately leading to premature cardiovascular events. In the examples that I'll show you of some of the work that we've done, we've looked at segregation, or in all of these examples, we're looking at segregation at the neighborhood level, and we're measuring it using this G statistic developed by Geddes and Nord. And the G statistic is a spatially weighted Z-score that represents how much a specific neighborhood characteristic, like income or race or ethnicity, deviates from that of the larger metropolitan area. So benefits of this measure is that it incorporates information from neighboring tracts. So it's a spatial measure. So we're looking at the tract that a person, census tract that a person lives in and the neighboring tracts. And then also that it takes into account the metropolitan area in which the neighborhood is embedded. So the more commonly used measure of racial composition, for example, percent Black, has a different implication in a city or metropolitan area that has a high concentration of Black people. So for example, the percent Black in San Francisco would mean something different than percent Black in Philadelphia. And this is particularly ideal for multi-site studies where we have a lot of participants who are from different parts of the country with different percentages of Black individuals. So a lot of the work that I do is leveraging these multi-site studies. So this makes this an additional conceptual and practical benefit of the measure. So just to kind of illustrate that with the G statistic, a Z-score of 0 in the San Francisco metropolitan area would correspond to a neighborhood that's 7% Black, and a G-score of 0 in the Birmingham metropolitan area would correspond to a neighborhood that's 28% Black. So I'll show you a couple of studies that we've done. This first one is using data from the multi-ethnic study of atherosclerosis. So this is a study of adults who were 45 to 84 years old at baseline, which was in 2000. And it includes, they recruited Black, white, Hispanic, and Chinese Americans into the study. This study focuses on non-Hispanic, Black, non-Hispanic, white, and Hispanic adults. But this is a study where the participants were followed for a median of 10 years. And we wanted to look at whether or not people living in more segregated neighborhoods were more likely to develop cardiovascular disease. And here we used own group segregation. So we actually stratified the sample, the participants by race, and looked at a race-specific segregation measure. And so what we found was that Black individuals living in more segregated neighborhoods were about 12% more likely to develop cardiovascular disease over the follow-up period. We saw no difference among Hispanic participants, and then in white participants, we saw an inverse association that seemed to be explained, at least in part, by neighborhood poverty. So maybe more of a socioeconomic explanation than racial segregation driving that association. And then another study that we did was looking at segregation in obesity. And so this was done in the coronary artery risk development in young adult study, CARDIA study. So in this study, participants were 18 to 30 years old at baseline, and baseline was in the mid-1980s. And participants were followed for 25 years. And so we leveraged this longitudinal design to look at segregation in 3 different ways here. So first at baseline, so when they were young adults, like a lot of times moving out of their parents' homes or out of college for the first time, and potentially still living with their parents. So this baseline measure, we looked at it as a time varying measure, so it kind of updates over time. And also as a cumulative measure, which is an average of the segregation scores across time points. We also modeled the associations in 2 different ways. So one using the standard discrete time hazard modeling, and then another using marginal structural models to address for the possibility of time-dependent confounding, particularly by education and marital status, and also to account for loss to follow-up. And so what we found, I mean, in kind of all the ways we measured it, it was fairly consistent that higher segregation was related to a higher risk of obesity among women and no relationship really among men. So to summarize, there is evidence supporting racial residential segregation as a fundamental cause of Black-white cardiovascular health inequities. I highlighted a couple of papers that we've done, and I wanted to just briefly mention some knowledge gaps that I see in this area of work. And one is prospective studies examining individual and neighborhood level mechanisms underlying these relationships that we're seeing. We were able to adjust for several things in this study, but I think there are more that could be accounted for to that might be driving some of these associations. And just in general, I think more prospective studies are needed. Sources of heterogeneity and associations of segregation with CVD risk. So what are the individual, neighborhood, and potentially policy level factors that might mitigate the impact of segregation on CVD risk? And then finally, identifying critical periods in the life course in which segregation is more harmful or beneficial. And one thing I just wanted to highlight about that is a conceptual model that kind of get us started to think about what that might look like by Gilberkey and colleagues, looking at generally at racism over the life course. What are the points in life that are affected most by exposure to racism? And so if you think about how segregation influences education, it may truncate the amount of time spent in education in the educational system, which could result in unemployment or underemployment. Segregation is related to incarceration. So there are things that would truncate the education time in education, and also the time in work, and ultimately lead to shortened life expectancy. So really kind of thinking about when that exposure is most critical, I think is a gap in the literature right now. So now I'm going to move into this addressing structural determinant side. And this is something I've continued to kind of come back to and struggle with how best to do this. But how can we as researchers empower communities and guide policymakers in their efforts to address structural determinants of health inequities? And so a lot of this that I'm presenting here is shaped by these two articles. One, how to embed a racial and ethnic equity perspective in research. And then the other one on confronting structural racism in research and policy analysis. And before I get into kind of their guiding principles, I just wanted to pose these definitions. I think there are a lot of ways that people think about these things, but first, structural racism. So knowing that it's not something that, recognizing that it's not something that a few people or institutions choose to practice, but instead it's more of a feature of the social, political, and economic systems that we all exist in. And then this idea of racial and ethnic equity is both an outcome and a process. So as an outcome, racial and ethnic equity is achieved when race or ethnic identity no longer predicts the course of a person's life, and all people have what they need to thrive, no matter where they live. As a process, racial equity is applied when those most impacted by structural inequities are meaningfully involved in the creation and implementation of the policies and practices that impact their lives. So then adopting this racial and ethnic equity perspective is applying tools that do give, recognize the unequal power differentials and access to resources and opportunities, while considering historical and current lived realities. So these are some of the tools. This next slides are more about the tools that we need to kind of adopt this racial and ethnic equity perspective. And so this starts out, I want to talk about these 5 guiding principles for researchers to consider. And what I liked about this part is that I think it's something that we can all consider, regardless of the type of research that we do. And the first is to examine our own backgrounds and biases. So to recognize that bias affects the decisions made throughout the research process, including who asks the questions, which questions are asked, whose input on the research is sought, how the data are gathered, how the findings are interpreted and communicated, and which audiences and methods are selected for dissemination. So we all need to examine our own racial, ethnic, and cultural backgrounds, as well as our experiences or lack of experiences with racism and or privilege, and consider how they influence the direction of the research that we do. The second one is guiding principle is to make a commitment to dig deeper into the data. So moving beyond simply documenting disparities towards an understanding of the potential underlying systemic and contextual causes of these disparities. So this requires asking questions to uncover root causes of disparities, seek involvement and perspectives of community stakeholders, and invest adequate time and money into designing and implementing the research. The third guiding principle is to recognize that the research process itself has an impact on communities, and researchers have a role in ensuring research benefits communities. So we need to actively work to ensure a lack of harm by being transparent with communities, listening to their concerns, and identifying what people want in return. Fourth, engage communities as partners in research. I think this is a principle that people have talked about a lot for a long time, especially in the kind of data collection and dissemination, but it's important to also think about engaging community stakeholders in all aspects, including data analysis, and offer, because community stakeholders can offer a perspective that differs from that of researchers. And then the last principle is to guard against the implied or explicit assumption that white is the normative, standard, or default position. So I think researchers, we typically a lot of researchers make comparisons to white outcomes when they examine disparities. And this can be helpful in terms of understanding what a target level of an outcome might be. But I think it requires also an understanding, or the potential danger of it is that it reflects an assumption that white outcomes are the standard, and they also apply positive values to cultural norms associated with whiteness and negatively measure people of color for those norms. So I think it requires an understanding of the structural factors and root causes that have led to these disparities, and understanding that while we need to improve outcomes for all, some of these solutions to achieving those will need to be tailored. So these principles can be applied to each stage of the research process. So in the very beginning stages of landscape assessment, or kind of gathering information about a community and their relationships, the design and data collection phase, data analysis, and dissemination. So now I'm just going to briefly talk about ways we can apply these principles in each stage of research. So landscape assessment, understand the historical and political context in which the research study will operate. I think this is something that can be done in the data collection phase, or in the data collection phase, but when you're doing a primary data collection study, but also in the secondary data analysis studies that we do. Providing opportunities for stakeholders to share their perceptions of the apparent issue or topic, and be reflective, again, about confronting the potential biases you hold. Design and data collection, here are some questions that would be helpful to consider as you're designing and collecting data for a study, such as, are the community's values represented in the research questions? Have the researchers identified how the answers to the research questions will benefit the community? Do the research questions account for the cultural and historical context of the community? And do you have a diverse research team that can bring their perspectives into the entire research process? So a lot of this is really saying we need to carefully choose a study design and data collection methods that promote equitable outcomes. And another thing I think that this is maybe is implied or also important to think about is we want to try and design our research questions with the potential intervention in mind. In the data analysis phase, it's important to go beyond, as I mentioned earlier, racial and ethnic group classification to look at structural and social determinants that might explain the observed findings. And one thing I think that many of us, I think quantitative researchers struggle with is data disaggregation. So it's important and a valuable tool to understand a topic or outcome by race or ethnicity, but it can obscure racial and ethnic differences seen in populations that have great ethnic diversity. So data disaggregation often focuses on racial and ethnic groups with larger samples, and may group other populations like American Indian and Alaska Natives, Asian American Pacific Islanders, into this other category. And so we have to think about how to handle that and how to kind of present that in our research publications, maybe by including caveats like about what inferences can actually be made from this other category when included. and at least suggesting that future research includes stratified sampling, but also with embedding a racial and ethnic equity perspective, it may sometimes mean that extra resources need to be provided or need to be allocated to oversample when needed to if we really want to be able to speak to the lived experiences of those of other populations that fall into this other category. The other thing is to think about here in this data disaggregation is the implications of including race as a dummy variable. So this approach, which is a common, I do it often, it makes this implicit assumption though that individuals are alike in every way except for their race. And that means that really assumes there's no relationship between race and any of the other explanatory variables in the model. But as we think about structural racism and the factors, the many systems and areas in which structural racism affects the lived experience, that might not be true, right? So these explanatory variables that are also in the model may not be alike for all individuals across the race groups. So I think there's not one way to do this every time. It depends on the race question, but it does imply that there may be instances where it's better to stratify versus to include everyone in the model when we're trying to understand racial and ethnic factors or the mechanisms through which disparities arise. And the last one is dissemination. So devising a comprehensive dissemination strategy that considers the language used, stakeholders as the key audience, and actionable results. And so there are a few ways we can do this that I highlight. There are many, but these are the highlights for me. Establish communication guidelines. So there are a lot of societies, organizations, and departments that especially now are creating guidance documents that share the social and historical context of various phrases, labels, and racial categories, and provide some guidance on labels to use and not to use, and how to best to avoid language that reinforces stereotypes about groups that have been marginalized in society. Diversifying dissemination products, so researchers can make their work more accessible by publishing a variety of products like technical reports, briefs, blog posts, podcasts, and infographics that can target different audiences. And then the last one I thought, which was really neat to me, I hadn't seen it before, was hosting data walks. So in a data walk, stakeholders would split up into small groups and rotate through stations, each one having a visual or textual display of data that forms a narrative about the community that participants can then confirm, critique, or complicate. So it's a great opportunity for researchers and community members to co-create meanings and solutions based on community data. So the last thing I wanted to share was just one example of how we could use, how we've used secondary data to get at some of these principles. And so this is a study we did using data from the Cardia study. So the one that I talked about before, where participants were 18 to 30 at baseline and recruited in the mid-1980s. So it's a multi-site study, and we used it to kind of leverage or kind of understand the impact of these kind of the Fair Housing Amendments Act of 1988. And so the Fair Housing Act of 1968 is the one that officially prohibited discrimination in the sale, rental, and financing of dwellings based on race, color, religion, sex, or national origin. And one big problem with that act was that it really wasn't enforceable. And so although obviously housing discrimination remains a big problem, the Fair Housing Amendments Act of 1988 served to expand coverage to prohibit discrimination based on disability, but it also established these new administrative enforcement mechanisms that allowed HUD attorneys to bring action against or on behalf of victims of housing discrimination. So one thing about this from the demography literature, it has shown is that it really did spark more cross-metropolitan integration. So Black people who moved out of segregated metro areas were more likely to move to less segregated metro areas, and that results in lower, they called them Black pioneers, but the idea is that this did successfully open up housing markets, and there were Black people who took advantage of that and lived in more integrated areas. So what we wanted to see is whether or not we saw some of that same phenomena in the Cardia study, and then ultimately how that influenced blood pressure for people. And so what we saw in the Cardia study is that people moved a lot over follow-up. So as I said, they were 18 to 30 years old. So this is a big time when people are making those first moves out of their parents' homes or out of college. And so between the baseline exam in the mid-1980s and 7 years later in 1992, participants went from living in about 10 different metro areas in the US to 100 different metro areas in the US. So especially at this early time point, there were a lot of big moves that people made. And we also saw that a lot of those moves were made to less segregated areas. So this is looking at within-person change in segregation scores between successive exams for people who stayed in the same place and for people who moved. And so we saw there's not really much change in the segregation score for people who stayed, but for people who moved, and especially in that first 7-year period, they moved to much less segregated areas. So it kind of fits that model that demographers have shown with the Black pioneers moving into less segregated neighborhoods with the opening of these housing markets. And so what we did was look to see whether or not these kind of moves to less segregated neighborhoods were associated with changes in blood pressure. And we found that Black participants who moved to less segregated neighborhoods experienced about a millimeter of mercury reduction in their systolic blood pressure when they moved to low or medium segregation neighborhoods. And we saw no difference in diastolic blood pressure. And this really persisted with a host of factors that we adjusted for. And you can imagine, so people may move to less segregated neighborhoods and back to high segregation neighborhoods, kind of fluctuating back and forth. So as a sensitivity analysis, we also ran this excluding those people who've been moved back and forth. And we saw even larger reductions in systolic blood pressure, around 5 millimeters of mercury for those who moved to low segregation neighborhoods and 3 millimeters of mercury for those who moved to medium segregation neighborhoods. So in conclusion, racial segregation is associated with a broad range of adverse health outcomes among Black people in the US. Developing policies that address the structures that produce inequalities and opportunity may have the greatest impact on health inequities. So the pervasive ways in which segregation influences a host of outcomes through all these different risk factors suggest addressing those root causes like segregation may have the greatest impact on health inequities. And then lastly, all of us can play a role in addressing the structural factors that drive health inequities. Looks like I was really into data, so I wrote data drive, but these factors are important and we can all play a role. So with that, I want to acknowledge the many different collaborators over the years on these different projects in Cardia and MESA, and open it up for questions.
That was phenomenal, Kiarri. Thank you so much. And we actually do have some questions that are popping up. Just as a reminder, please put all the questions in the Q&A. It'll help facilitate me being able to follow them. So here's the first question, Kiarri. So the racial residential segregation map that you showed was circa 1970. So this is the one from Chicago. At that time, there was huge white flight happening. Can you determine the differential impact of white flight versus neighborhood disinvestment and redlining, or is this like a chicken and egg issue? So is there a way to kind of determine what's actually happening or driving what's happening in those neighborhoods is the question.
Yeah, that's a good question. I mean, I think there were several things happening at the same time. So I'm not sure that you can really, so maybe that means it's more of a chicken and egg issue, but I think it was actually I think it's a good example of the structural nature and what structural racism is that it's multiple sectors acting at the same time So I think, yeah, it is hard to disentangle which happened, but yeah, there's some active work with, I guess, for example, what am I thinking of? Real estate agents, encouraging people to leave and then upcharging on the houses that are there for Black people. So I think, that's one aspect of it, but then there are other aspects of it. So I think, yeah, that's my longer version of chicken and egg, maybe the way to say it.
Okay, absolutely. Okay, so the next question is, so former welfare laws required that the household head, often a female, could not have a male provider in the home or display. Do you think that this perpetuated the decline of minority neighborhoods? And this is a question they ask because often there is this perception that Black neighborhoods are economically depressed and blighted due to the fault of residents. So do you have a response for that question?
That's a great question. I think, I do think that the laws, former welfare laws, and even housing laws. So, I mean, there's a good example comparing Chicago. I mean, I guess it's not comparing, but Chicago's housing laws and New York City's, for example, affordable housing laws, that where Chicago was so restrictive that really only the poorest of the poor qualified for the restricted housing, and then left a lot of middle income Blacks behind, but then also really provided poor resources for the people who needed it the most, whereas they were a little looser for New York, and a lot of the public housing developments in New York were much more supportive and helpful. They saw a lot better outcomes in those kind of environments.
Absolutely. All right, so here's a next question. Great talk. So you mentioned some of the mechanisms by which segregation affects health that need to be further explored. This person wants you to talk a little bit about what some of those might be. They say, to me, it makes sense that segregation combined with inequitable access to resources could lead to disparities, but alternatively, maybe that the level of segregation in a city might be a proxy for the level of racism. And I'd love your thoughts on whether these or other mechanisms are likely important or explain these big associations.
Yeah, that's a great question. I mean, I think both are true. I mean, I think the level of segregation in the city could be a proxy for racism, both, I mean, potentially interpersonal, but for sure at a structural level. And that pervades many domains, not just housing, I guess. So, right, it could be a proxy for more healthcare related housing, education, these multiple factors that we know are related to cardiovascular disease and other health outcomes. But then segregation also drives access to resources. So it's not even, it's a bit combined, except for that's part of what segregation is. So it's not the random or preferred, it's not a reflection of preferences, I guess. It's more of a reflection of these structural factors that intentionally redistribute resources. And so I think those are close to the same thing. And when I think about it, because it's not just combined, it's like that's what's causing it. It's a process, I guess, really, that's driving that.
Yes. Okay, great. Thank you so much. Are there any other questions from the audience? Any other additional questions? This was such a rich talk, and so many different. Your work is, it's been that you've been doing with Cardia and Mesa has been phenomenal. Any additional questions from the audience?
I think I see one about interventions.
Oh, I see one. Okay, so wonderful talk. Do you know of any studies that found that residential segregation improved cardiovascular health among Blacks, and why do you think? And if so, why do you think that might drive this relationship?
I haven't seen any that have shown that it improves cardiovascular health. I think that there is some discussion or kind of some papers talking about its relationship with, I'll say two things. One, in relationship with mental health outcomes. And so that's kind of think that's the ethnic density hypothesis. So this idea that living in segregated areas would protect from direct experiences of racism. And so there is some literature on that. And then the other part, I mean, I think this is the opportunity for this kind of exploring heterogeneity, and we haven't been able to do that as much as we like, I don't think, because some of the studies that we are using are great in a lot of ways in terms of the longitudinal aspect, but the way that people are sampled in those studies there's some race-based neighborhood sampling. So I think we aren't often capturing the diversity of segregated neighborhoods that we see in our country. So I think there's more work to be done if that's rarely the primary goal of a study, a data collection. So we're often working with data that we have, but I do think that could be why we're not always seeing that, especially not even with the effect modifiers that I think many of us are trying to understand, like, oh, when would it be less harmful? And I think it's partly a data issue.
Yeah, no, I think that really ties in. One of the books that I reference quite a bit is the Black Picket Fences about Black middle class neighborhoods. And we just don't have enough data in some of these large cohort studies to really disentangle and understand what Black middle class neighborhoods do for health. Are they slightly more protective, or are they kind of bogged down by their proximity to lower income Black neighborhoods, right? And so I don't think we've been able to do that much.
Yeah, I agree. I like that book too.
Yeah, so let's see. I think there's some more questions coming through. This is another question. You didn't touch on this in your talk, but do you care, or do you have time to talk about some of your work in agent-based models and what you found with some of that? I think that was work you did for your K, if I'm not mistaken.
Oh yeah, well, we are, so that has been a journey more aspirational than anything else, but just recently we've been working on kind of integrating a deeper look at the food environment to other agent-based models that have focused on social influence. So really trying to map out the resources specifically available in Chicago. So trying to kind of in real, in that kind of real layout, understand the extent to which the location and types of foods in different locations is driving eating behaviors, specifically fruit and vegetable consumption, and also kind of how extreme the distribution of those resources would have to be to overcome some of the other factors that are driving disparities in food outcomes. So kind of playing with the location of them based on where they really are, but then also kind of food budgets and actually the quality of the foods that are available. So that has been something that I've been wanting to do. And I think if I was like, if you write it down, you have to do it, right? So then we finally have like a rough model. But the idea is to try and use it and really use it in Chicago and try and think about once we get a good validated model, what interventions might look like.
Right, exactly. So can a follow-up question to this is talking about the food environment, does it, do you look at kind of some of the non-traditional ways in which, for example, Black communities, kind of fill the gaps, right? Urban farming and all those kinds of things. Are you able to incorporate that into your thinking or into the models at all?
I mean, we should, yeah. I mean, when you talk about, I think there are data. So some investigators in Chicago have recently put together a kind of a, I think it's an ArcGIS hub, it's called, but to give people information about food access in Chicago, during the, actually a lot during the civil unrest too, and some food sources, like some places obviously only have one or two, and then that disappeared. And so helping people find where to get food, they've tapped into some resources and kind of made some of those publicly available. And one is at least about farmers markets, and I don't know that it would include everything. And there may have been something about urban farming, but yeah, I think that there's there's a need and it can be done if we have the data to incorporate those non-traditional sources versus right now we have the NETS data, so it's more of the business.
Right.
But that's a great point, though. We need to kind of incorporate some of those informal sources. So it definitely can be incorporated in the model.
Yeah, absolutely. Let's see, there's one more question. What are some of the other well-established causal mechanisms linking CVD and residential segregation outside of, like, for example, increased allostatic load?
Other than allostatic, so other than stress mechanism, I mean, I think a big pathway is like these kind of different stress pathways. I don't know if it's necessarily allostatic load, but this idea that there's this kind of long buildup of physiologic dysregulation due to kind of exposure to stressful situations. But I think, yeah, there's also the other part of it is kind of environmental affordances. So James Jackson used to talk about that a lot, like what is available to you as a way of either coping with stress or just kind of surviving, eating or, time, I think, is a big one too. But so, I think that's what it does. It gives you a constrained set of choices to make, like certainly a set of easy choices to make around health behaviors that can then influence CVD risk. But it's hard to kind of separate one versus the other because the stress part versus the environment.
Absolutely. And then I guess in closing, do you want to give any preview to the review paper that we're working on? Like, I think there were some interesting things. So this review paper is looking at different measures of segregation, and then also exploring how Hulk maps are also now being used too. So you wanted to give any highlights or high level points from that?
Yeah, no, I mean, I think it was a good exploration of the pros and cons of the different ways that we conceptualize segregation. I think a lot of times we are using kind of the simple or easier to measure kind of percent measures. But in that paper, we talked more about not just segregation, but also like the consequences of segregation and how we can measure that. And then the things that drove it initially, like the historical measures of segregation, the Hulk maps. I think for me, that a good thing about that was understanding the pros and cons of each of them. Like, so there are things that are great about the Hulk map, but there are a good number of actual limitations when you go to implement it because neighborhoods have changed, boundaries have changed, and they're not actually relevant to large parts of the country. So it's just really trying to understand what that represents and what you can speak to. I think one of the things that we saw were people trying to adjust for this kind of change in the neighborhoods and then ended up either restricting the data in some way so that you only use the data that you can speak to versus I guess just saying that the boundaries are different, but it gets more complicated. I think it's richer. We're getting a richer picture, and like the ICE measures we talk about and what they speak to. But yeah, I think it'll be a good toolkit for people who are interested in segregation and really, again, like this whole idea of understanding historical and structural context. What are we trying to get at? Like, what is it really that you're trying to capture by the measure of segregation, right? It represents a variety of things, and that I guess speaks to some of these questions about mechanisms, and that could help guide which measure is really the most important. And what are you going to intervene on, I guess, is the other part of it, right?
Absolutely. So one more question. So, the role of, we have these striking racial inequities that exist. They have persisted. There are these structural drivers, but there's also, now that a lot of folks, for example, in the medical field are, more attuned to that social and structural determinants of health, there might be this tendency to assume, if you come into a doctor's office as a Black person, that you then therefore have high blood pressure or whatever. So, this person asks, when you think about, like, how do you balance that out, that, we know that there are these striking inequities, but also not, run the risk of making these assumptions. And does this become almost a self-fulfilling prophecy in some ways when we're inundated with the data that show this, but so where do we draw the line and how do we balance that out?
Yeah, that's a tough question. I mean, I think it's like a subject of debate. I know one of the working groups that we had here about addressing structural racism, one was about whether or not, and I wasn't part of this group, but whether or not people should report race when they're giving like the summaries of people's conditions, like when rounding at a hospital or something, or in classroom settings when they're explaining a condition, like a case or whatever, a person, whether or not that's okay and like the implications of it. And I think you have to think it's a kind of context specific, like why does it matter, right? What is it about the race that is mattering here? Are we talking genetics? And if not, then should we be using race, or should it be some other social factor or what? And it's complicated, but I think it's worth having that conversation again, because like what are we trying to capture when we are asking them race? What does that mean? And then the other thing I would say is this idea of structural competency and looking at, so it's, and part of that is screening for these unmet needs, also obviously being able to address them, but that can get at what somebody needs in a better way than just using the race to be a proxy for that, right? Because that gets at, actually addressing the problem.
Right. Yes, I've seen like some places now doing more with zip code. And things like that might be a little bit more helpful in terms of getting at those issues as opposed, like you said, to race, because that race is really a proxy. So well, those are all the questions I have for you. I just want to say again, it's always a pleasure to hear you speak, and all of the wealth of information and research that you're doing. That's phenomenal. Thank you so much. It's been great. Thank you to the audience for being so attentive. And I think, again, this was our last invited speaker series for the Urban Health Collaborative for the year. And so look forward for our speaker lineup for next year, sometime in the fall. But again, thank you, Dr. Kershaw, for joining us today for this speaker series.
Thanks for having me. Good seeing you again.
All right, take care.
Bye.